Now, this is a very common question which comes into the mind, that which antihypertensive to use in a particular patient. Now, we will see some of the clinical conditions where we can decide which antihypertensive to start with. So, if the patient has hyperuricemia, if some patient presents to you who has hypertension and who has uric acid of 9 or 10 or 8 or 7.5, if it is high, then you can always see whether the patient is on Lasix or torsemide or hydrochlorothiazide or chlorhexidine. Because if the patient is on these medicine, then all of these medicines can definitely cause hyperuricemia. So we need to stop these medicines and we need to change this medicine to either cilnidipine or losartan, because both these medicines cause excretion of the uric acid. So this drug is causing increased uric acid, so we need to stop this. We need to switch that drug from this to this. So we can always choose the cilnidipine 10 milligram or losartan 25 to 50 milligram, and we can start it. If any patient with hypertension has pedal edema, which is spitting in nature, which is very, very commonly seen, then we must know that amlodipine is one of the excellent drug for hypertension, but very commonly causes pedal edema. So if the patient has pedal edema, then we can simply stop this amlodipine, and we can add cilnidipine, because the chances of pedal edema with cilnidipine is much, much lower compared to amlodipine. And in such patients, we can give furosemide or torsemide for even 5 to 10 days. The 5 to 10 days course of this furosemide or torsemide, we can use 10 milligram, 20 milligram once or twice a day. We can use that, or 5 milligram to 10 milligrams also. We can use it once or twice a day for 5 to 10 days, which can definitely markedly reduce this pedal edema, and we can stop it. The most important thing we need to tell is we need to restrict total free food water intake, because many of the patients drink more than 3 liters, 4 liters, 5 liters, 1.5 to 2 liters of water per day. And in a patient who has no heart failure is sufficient. Any patient who has heart failure with pedal edema, we should strictly ask them to restrict their food water intake to 1 to 1.5 liter per day. The next thing is any patient, if they have increased risk of hyperkalemia, or if they have acute kidney injury or CKD, and in such cases we should definitely be very cautious to avoid spironolactone or eplerenone or ramipril or telmisartan or ormisartan, because these are the drugs which can definitely cause hyperkalemia. So these drugs are not absolutely contraindicated in CKD or in AKI or in hyperkalemia, but you need to make sure if there is a significantly increased risk of hyperkalemia, or if the patient has hyperkalemia, then these drugs can significantly increase potassium, and patient may have sudden cardiac death. So in that scenario, just make sure these drugs are not given for maybe 2 to 3 days. Once the AKI, acute kidney injury, settles, or once the risk of hyperkalemia is much, much lower, or if the patient tolerates these drugs very well without increasing in the serum potassium levels, or without a significant rise in serum creatinine, these drugs can be continued. So, as I told, if the patient has pedal edema, furosemide, torsemide, furosemide can be given 10 to 20 milligrams twice a day. Torsemide can be started with 5 milligram to 10 milligram twice a day. Most of the time, this can be sufficient. The dose can be increased if there is inadequate response. If any hypertensive patient has shortness of breath, if they have crepitations on auscultation, or if there is saturation is low, so saturation is low, it means automatically there will be accumulation of the fluid, accumulation of the water in the lungs. It means the patient may be in the fluid overload, or the patient may be is in the LVF, that is left ventricular failure. In that scenario, again, giving furosemide, torsemide can definitely increase diuresis. It can reduce the fluid overload or fluid burden in the lungs. So automatically the lungs shortness of breath can be improved. The crepitations will reduce because of the washing out of this fluid from the lungs through the body, and the saturation will definitely improve, because there will be lesser water in the lungs accumulated, so which can facilitate the oxygenation. If the patient has no heart failure, but if the patient has persistent tachycardia, like the patient is apprehensive, then in such cases, beta blocker can definitely be added, because beta blockers, they tend to reduce the heart rate, they tend to reduce the excessive uh, mm, tachycardia, they increase the vagal tone, so automatically the heart rate may reduce. And very commonly, tachycardia causes angina, chest pain, because heart gets less time to relax. So if the heart rate get better to less than 90, then automatically heart gets more time to get in relaxed mode. So automatically the coronary feeling improves and the chest pain or angina improves. So in such cases, evaporating can be also added if the patient has heart failure component with it. Any patient, if is presenting in acute heart failure and if they have V's or rhonchi, especially if these V's or rhonchi are present up to more than 10 centimeter from the diaphragm, then beta blockers are contraindicated, because beta blockers are known to cause bronchoconstriction, and they are actually absolutely contraindicated in acute heart failure. Any hypertensive patient, if they have heart failure with reduced ejection fraction as well, if the EF is less than 40%, but they are stable, means if they are not in acute heart failure, then we must know there are a total 5 drugs which are called pillars of heart failure. Each and every patient who has EF of less than 40% must get these 5 drugs. The first one is beta blocker, because they will reduce the heart rate. You can use metoprolol, carvedilol, nebivolol, any drug we can use, but these are very, very must to reduce the heart rate or to make heart rate at an optimum level, to improve the diastolic function, to improve the systolic function, and to reduce the cardiac workload. Sacubitril valsartan, which are one of the excellent drug, and they have shown significant mortality benefit, morbidity benefit, and heart failure hospitalization benefit also. So all these benefits are there with sacubitril valsartan. The third drugs are the SGLT2 inhibitors, which were actually started for patients with diabetes mellitus, but these drugs have shown to have not only the cardiac benefit, they are shown to reduce the morbidity, mortality in heart failure, as well as they have also shown to have a renal benefit. So there is a decrease in this proteinuria, there is better chances of lesser progression to the CKD. So these drugs must be started in all patients who have EF of less than 40%. We have to make sure that urinary tract infection is a very, very, very common problem. So whenever a patient who is prescribed SGLT2 inhibitors like dapagliflozin or empagliflozin, you have to make sure that you always do urine routine and microscopy. And whenever there is UTI, you have to treat it completely. You may need to stop this medicine for maybe a few days, and you can restart the medicine once the urinary tract infection is settled. The fourth very important drug is spironolactone or eplerenone, which actually basically is an aldosterone antagonist. And we must know this aldosterone is a part of renin-angiotensin aldosterone system, and it causes fibroblastosis. And it is basically the drug which causes remodeling of heart, remodeling of endothelial, remodeling of so many structural things in our body, which causes progressive heart failure. So to prevent that progressive heart failure, to prevent this fibroblastosis, to prevent this remodeling, spironolactone, eplerenone, or amiloride is very, very important. The AC inhibitors like ramipril, these are very, very important medicines which are shown to have a mortality benefit, morbidity benefit, hospitalization benefit in a patient who has heart failure. So this drug should be always considered to start with in any patient who has heart failure with a reduced ejection fraction. This holds true in any patient after MI with left ventricular dysfunction, or those patients who must have this mortality benefit or morbidity benefit or the quality of life improvement, because the sacubitril valsartan and other drugs for heart failure markedly improve the quality of life. They can improve the exercise tolerating capacity, markedly improves with these drugs. whenever there is any hypertensive patient with proteinuria, because urine routine and microscopy is very commonly done. So in urine routine and microscopy, we should always see whether there is presence of proteins in the urine or not. It can be 1 plus, 2 plus, 3 plus, and we should always ask to do urinary albumin creatinine ratio. If this is high, then this always suggests that the patient has high risk of progression to chronic kidney diseases. So, in such patients, we should add a drug to prevent or to stop this proteinuria or leaking of the protein in the urine, which will automatically prevent the patient to go into CKD early. So, the ACE inhibitors like ramipril, it can be used very commonly to prevent the CKD progression, and beta blockers also are very commonly prescribed to prevent the CKD progression and to prevent this proteinuria. Any patient who has CKD, who has significantly increased risk of hyperkalemia, I already told, we should be very cautious and we should be very keen to use the ACE inhibitors or angiotensin receptor blockers. The hydrochlorothiazide or chlorothalidone, they won't act, or Lasix or torsemide if the patient is already in end-stage renal disease or stage 5 kidney disease. Then the furosemide, torsemide, these drugs will not at all work because they won't reach the loop of Henle. And these ACE inhibitors and angiotensin receptor blockers, eplerenone, spironolactone, they can markedly cause hyperkalemia and patient may have sudden cardiac death. So we have to be very cautious whenever we are using these drugs in a CKD patient. End-stage renal disease, or whenever the GFR is less than 15, the furosemide, torsemide, these are not effective at all. So they will not help to create or to produce urine at all. The creatinine or GFR can be very easily calculated by the formula 140 minus age into weight in kilograms divided by 72 and into plasma creatinine. This must be routinely used in any patient, and you can immediately calculate the EHF GFR, and based on this you can calculate the dose of antibiotics, drugs, or all the other medicines which are used for the management of the patient as per this GFR. Any patient who has mild to moderate renal disease with oliguria, so in that scenario, we can use metalozone. This is one of the very beautiful drug which is even effective at the GFR of 15 to 30 ml per minute. So very commonly, if the patient is already on furosemide, torsemide, and even after that, if the urine is not produced, in that scenario, we can add this metalozone. Very commonly, 2.5 to 5 milligram twice a day is added, and most of the time it is sufficient. We must know that in CKD or end-stage renal disease, there are so many drugs which are contraindicated, or where they have to be used very cautiously, like ACE inhibitors, ARB, this spironolactone, eplerenone, furosemide, torsemide. So these many drugs become very much ineffective or very much risky. So automatically, uh, the drugs which we can use in chronic kidney disease or end-stage renal disease are moxonidine, very commonly 0.2 to 0.3 milligram twice a day is used. Prazopress or prazosin, 5 milligram twice a day is very commonly used. Cilnidipine, 10 to 40 milligram per day can be used. Beta blockers can be used, but you have to look for bradycardia, or patient should not develop more than second degree heart block. Or clonidine can be used 0.1 milligram 3 times a day, or 0.2 milligram 3 times a day. If the hypertensive patient is healthy, normal, if they don't have any issues, then any of the drug can be used, like angiotensin receptor blocker, telmisartan. It can be started from 20 milligram and can be given up to 80 milligram. Olmesartan can be given 20 milligram, 40 milligram, or 80 milligram very commonly. Calcium channel blockers like cilnidipine can be given 10 milligram, 20 milligram, or amlodipine can be given 5 to 10 milligram as well. Beta blockers like metoprolol, atenolol can be used. Chlorthalidone or hydrochlorothiazide can be used separately or can be used in combination with these drugs. If the systolic blood pressure is more than 160, it is very unlikely that the blood pressure will get controlled on single drug. So in that case, we can simply start with a combination medicine. So we can start with dual or triple drug therapy as well. So we can simply start like telmisartan or olmesartan plus cilnidipine or amlodipine, or we can use metoprolol or chlorthalidone or hydrochlorothiazide as well. So what like you can use telma ACT, which will give this telmisartan, amlodipine, and chlorthalidone, or like you can use Telista CL, which will give you telmisartan, cilnidipine, or telmisartan ACH, which will give you telmisartan, atenolol, and cilnidipine. So there are various combinations of the drugs where this drug is combined with either these two, or this drug is combined with these two, or this drug is combined with this one, metoprolol and chlorthalidone. So such double or triple combination drug can be used to have a effective blood pressure control. So thanks for today. Thank you.